so I don't forget to record it. And now I'm going to share my screen, and no, that's not the screen. You don't need to see my busy life. Let me go back to my share screen. And I'll move the chat feature out there, and I'm going to move these folks over here so I can see the PowerPoint. Okay. So just to be sure everyone is muted, I just want to make sure I've got. So the first part of the presentation will be covering GI health challenges, and I'm sure that in your clinical you have already experienced a lot of the older adult, as well as in the early part of the semester, patients that were experiencing abdominal health challenges. The learning objectives for this session will be describe assessment and management of various types of ostomies, discuss patient teaching related to ostomies, describe common diagnostic and lab tests involved in assessing the GI system, describe common GI surgeries, including indications for post-op nursing care and patient teaching, explain common etiology or causes, clinical manifestations and nursing management of upper and lower GI bleeding, explain the collaborative care and nursing management of acute appendicitis, peritonitis, pancreatitis, and gastroenteritis. And we're just going to sort of start with one and we'll extrapolate the others. Compare and contrast ulcerative colitis and look at the common causes of abdominal pain. One of the things that you're probably quite familiar with and been exposed to, and I just want to make sure I'm still recording. Let me just make sure. Oh, I just want to make sure I'm still recording. So one of the things that you are probably been exposed to already is Gerdes. So with Gerdes, it's quite a common phenomena in the hospital, and Gerdes can lead to other complications. So I thought we should talk a little bit about Gerdes, as there is really no one single cause of Gerdes. There's several factors or combination of factors that can be involved. It occurs when either there's an incontinent sphincter emptying into the stomach, and there's backwash of stomach acid into the esophagus. Sometimes the patients will have a pre-existing hiatus hernia, so that the esophagus is starting to herniate through the sphincter itself. There's an incompetent valve, and so what I mean by that is, so it's not coming together nice and tightly. It sort of has a leaky area, and so acid is coming from the stomach and washing back into the abdomen. It results in impaired esophageal motility. So as this area is inflamed, and it's almost like a burn, a superficial burn, because of this gastric acid. And this causes a lot of irritation, that gastric mucosa. And in fact, you can have that into the stomach as well and cause a lot of irritation. Clinical manifestations for GERDs include that burning in the chest area. They'll have that real burning, as well as they'll often have a lot of eruption or gas. They'll feel very gaseous, and they'll be belching as well. But it's really this burning. And I do want to caution you that when we talked about cardiac a couple of weeks ago, or months ago now, when we talked about cardiac, we talked about how we assume that any kind of chest discomfort, burning, pressure, any of those symptoms, that we always assume that they are myocardial ischemia first, and then we would say, oh, it's GERDs. And remember, we talked about the pink lady, where we give an ounce of, or 30 mils of Maalox and 5 mils of lidocaine viscous to help coat the esophagus, and if that tends to take that pain away, it may in fact be just GERDs as opposed to any kind of ischemia. So medications that are most prevalent with GERDs would be your H2 blockers, so your cimetidine or your ranitidine. and they're actually available now over the counter. Proton pump inhibitors like your Nexium, prokinetic therapy, and prokinetic therapy is something that's going to facilitate the emptying of the stomach. So you don't have that gastric acid sitting there. It's going to help push it along. And so medication that we call that's commonly used as a prokinetic therapy would be metoclopramide or Reglan. That was one of the earlier anti-nausea medications. It actually facilitates gastric emptying. So the rationale was that if there's nothing in the stomach to vomit, they wouldn't actually vomit. And then cholinergic drugs. Gosh, a couple of little spelling errors there. Cholinergic drugs that help to dry up all of the gas secretion. To diagnose GERDs, and again, you can start to see how your concept map starts with GERDs, how you've got your pathophysiology, your risk factors, and now we're going into our clinical manifestations, and now we're going into diagnostic tests. And typically to diagnose GERDs, it could be done first with a barium swallow. So remember we talked about a barium swallow a couple of weeks ago where the patient is NPO after midnight for an esophageal, stomach and duodenal swallow. The patient is kept NPO and they're given some barium, which is radioactive, and they swallow the barium, and it actually follows the lining, and you can see if there's any masses or that sort of thing. So they're seeing if there's any abnormalities in that stomach through that barium swallow. However, it is only with the scope that they're actually to take the scope in and feed it in and examine all of the mucosal lining. And so it's only when they really see the scope when they can see some of the redness or the irritation in the esophagus. The interventions for GERDs would be keep the patient elevated, keep the head of the bed elevated. And so at the hospital, it's merely simple, just putting them into semi-Fowler's or high Fowler's position. When they're at home, they talk about putting the bed up on, about raising the head of the bed about 10 centimeters on blocks. And so just to get blocks of wood, maybe 5 inches of block of wood, and put the head of the bed up on that, just to help the gravity pull the gastric acid down out of the esophagus. While we talk about elevating the head of the bed at home on blocks, I've never really found that that's been an effective way. People have a difficult time getting their bed up onto blocks. So even in the, if you don't have any blocks or the patient is elevating, even if they get a couple of pills and keep their head of their bed elevated, keep themselves elevated, it will help gravity to pull the gastric contents down into the stomach. Another intervention for GERDs would be a high-protein, low-fat diet with the avoidance of foods and fluids that would decrease the pressure or irritate the acid in the esophagus. And sometimes that's just very highly specifics. Of course, you want to tell them to avoid caffeine, cigarette smoking, and maybe aspirin or other medications like Advil, something that's going to be known to irritate the gastric lining. Complications of GERDs is that after a period of time, they can get scarring. One of the more serious complications is that when they're sleeping and the gastric content washes back into their lungs, so they aspirate, they get this bronchospasm because of irritation of the bronchi with this acid solution. So they have a lot of wheeziness and bronchospasm. They can, depending how severe, they can desaturate, but also aspiration pneumonia is a big concern. And so this, I had a internal medicine say that, okay, you can get one free aspiration and you should be okay. But after that, you're going to start to see scarring in the esophagus and in the lung fields from the constant washing, the flow back of this gastric acid. Moving down sort of the GI system, and I just wanted to make sure I touched on the priorities. I just wanted to really emphasize some of the seriousness of an upper GI bleed. And I think I've mentioned in class around that you're going to walk onto your unit and you're going to say, okay, who's bleeding? That smell of blood, that melena or hematemesis, is very pungent, and you're going to smell it. And by the end of your shift, it's going to be permeating your hair. It's going to be, you just want to get into a shower because you can smell it so profoundly. So an upper GI bleed represents a significant clinical and societal burden because of the associated morbidity, mortality, and financial implications. So an upper GI bleed, and I just want to remind everyone, I think I shared this with you, that my very first cardiac arrest was actually a GI bleed that went unrecognized. Being a new grad, I certainly was following the lead of my team, and they really missed this GI bleed. So that when I went in to do my rounds at 6 o'clock, this patient was quite unconscious because he had actually was hypovolemic from GI loss. And when I actually started mouth to mouth, because in those days we did mouth to mouth, we don't do that any longer. We did mouth to mouth, and he just covered me in blood. I was just speckled from head to toe with blood. And I know I'm hearing all your gasps, even though you're all on mute. It was quite substantial amount of blood loss, and it was my very first cardiac arrest. And I was on night shift with Mrs. Hamilton, who was a pediatric nurse. So again, putting the new nurse in an unsafe situation. I was in charge with a nurse that did not know the adult population. And so when I asked her to call a cardiac arrest, she didn't know how to. And I felt I was there by myself for a very long time. The outcome was that the patient did live, but I just can't emphasize how important it is to recognize early signs of GI bleeding. So GI bleeding is quite prevalent in our society. A lot of the older adults will bleed because they're on a medication. We have younger folks bleeding because of genetic predispositions, as well as we'll talk about some of those causes around H. pylori. GI bleeding, as I mentioned, you just want to be very astute to the early signs of GI bleeding. In the past, we typically would see maybe the older adult, perhaps more females would be have GI bleeding, but they thought in those days it was related to the NSAIDs, so the non-steroidal anti-inflammatories, and women have a little bit higher incidence of NSAIDs. Now, and they were saying that GI bleeding, there hasn't really been a lot of change in that, although I've seen from when we used to take patients for these massive big surgeries from a GI bleed to now they just slip a scope down and they sclerose the lesion and they're out of the hospital in no time. But it still has quite a huge burden of disease. The signs and symptoms that you might be exposed to. So the patient may actually bring up frank blood, and depending, it can be both an arterial bleed, so that the erosion or the ulcer has eaten into the arterial blood system, and the stomach does not like blood. It irritates it. Blood is irritating, and so it'll actually try and get rid of it or eject it by patient vomiting. So they may vomit this frank red blood. And again, I have seen where we've had wash basins full of blood. So you're going to see this frank, they call it frank bleeding, or bright red blood. It may have clots in it because it's already coagulating. It is fresh red blood, and it will be quite profuse. And so if it's bright red blood, that means it has not been in contact with the stomach's acids. You may see the patient vomit coffee ground looking materials, and so it's that brownish kind of mucky hematemesis. And so if you're seeing coffee ground, it looks brownish with the fine little specks in it, coffee ground, that means that the blood has been in the stomach for a bit longer period of time, and it's actually more digested, and it has been in contact with gastric secretions. And so really important that you distinguish between the two. If you're unsure, get those dipsticks that we talked about and just dip it to see if there's any blood present in the stomach content. We've had some massive GI bleeds, as I've mentioned, and those GI bleeds can actually be vomiting, over the course of a very short period of time, over 1.5 liters of bright red blood with clots. When I'm seeing that kind of blood loss, I'm thinking that represents upwards to 25% of the intravascular blood volume. So that's a huge concern to me. And we'll talk about that around medical surgical emergencies. Now, I just also at the same time with this GI bleeding, when you have a stomach bleed, so you have a stomach ulcer, and the ulcer can be high up in the stomach, it can be lower in the fundus of the stomach, or it can be closer to the duodenum or in the duodenum. If there is a bleed up there that is started to move on down the GI tract, again, the intestinal tract does not like blood, and it will try to eject it. So the patient will experience this bleeding rectally. So if it's from the upper GI tract, it will actually be expelled from the body as what we refer to as melena stool. It would be that black, tarry stool. And that black tarry stool is really, again, significant finding, and that is concerning that this patient is actively bleeding in the upper GI tract. So if it is formed stool that is black in nature or black and brown in nature, then you'll find that it's not as it's been sitting there for a little bit of time, so maybe up to a day it's been sitting there as it's now become formed stool. What you'll often see is this loose black tarry liquid, and that is what we refer to as melena, and it will have a pungent odor. So that is really as the blood is being digested on the upper tract and it's moving down through the lower tract. So what causes stomach ulcers? And a lot of times it is due to medications. Some of the medications that are highly erosive, or medications that cause bleeding or GI ulcers, would be non-steroidals. Very, very often will cause bleeding, and that's why if you're taking Advil or your patients are taking Advil, you want to make sure they take it with food. And I always make sure that they take it sitting up. So even in my personal life, I would not have anyone take an Advil and then go and lie down. You want them to sit up for an hour so that you don't get that backwash of highly acidic stomach contents washing back into the esophagus. So Advil, what is that other, naproxen, any of those Mobicox type 2 inhibitors, any of those medications will cause a lot of GI bleeding. Of course, aspirin will, salicylates will. So if your patient is having a GI bleed and they're on low-dose aspirin, they need to come off very quickly. Bleeding from the upper GI tract can also be a result of situations in the esophagus. One of them is called an esophageal varices. Esophageal varices are caused by the portal hypertension. So there's a situation occurring in the liver, there's liver disease, and it's putting pressure back up through the rest of the system up into the esophagus. And so it's in the venous side of things. So now you've got this portal hypertension putting pressure forward, and now you have venous dilation, and it's really an esophageal varices is like a varicose vein in the esophagus. So just like you would see on somebody's leg, that the incompetent valves that are not pushing the blood forward but allowing it to flush backwards, you're getting those esophageal varices around the esophagus. You can also see varicose veins or varicosities in the rectal area, and we call those hemorrhoids. So around the esophagus, you're going to see these esophageal varices, and because they can get quite large and they can rupture, these patients bleed massively, often associated with patients with liver disease or liver failure. And so these patients with liver failure, and it could be cirrhosis or non-cirrhosis liver disease. It could be alcohol or non-alcohol related. So I just want to remind everyone that we just don't assume someone who's coming in with liver disease, they shouldn't be drinking. Not always is liver disease associated with alcohol intake. So these patients have these esophageal varices that are quite profound. There's usually more than one. And when they rupture, when they blow, they really blow. So we have to be prepared for that. What they do with those is they get them into the ICU. They get the gastroenterologist to come in and they do a scope, and they actually sclerose them or inject medication into them so that it actually collapses them. So the patient has esophageal varices. You'll also hear the term Mallory-Weiss tear in the esophagus, a Mallory-Weiss tear. And that is really just from vomiting. So people that have had maybe chemotherapy that have vomit with such force, they tear the esophagus and cause a GI bleeding from the upper tract. In the stomach and duodenum, GI bleeding often occurs because of gastric cancer or peptic ulcer disease. Those are sort of the reasons why. The other reason I don't see it as often, but it does happen from time to time, is that you may see a stress ulcer. Oh, did everybody get the PowerPoint? Sorry, I didn't see that final comment there. So the stress ulcer occurs as a result of someone being very ill, and they have that fight or flight response. And I hope everybody can remember the fight or flight response from A and P. And so they have the flight or flight response. So they have a lot of adrenaline flowing for that, to fight off that infection or whatever their illness is. So they're usually very sick patients. They haven't been eating. They're too ill to eat. And so they have a lot of stomach acid, and also the mucosa starts to break down. So they have multiple areas where they start to break down, and all of these become quite edematous, and they begin to bleed. Other reasons for upper GI bleeding could be blood disorders. So they term that blood dyscrasias or blood disorders, that the patient for some reason has thrombocytopenia or a decreased platelet count. They have nothing to actually clot the blood, and so that, or something that's really causing the clots to break down. So leukemia as one that comes to mind. I think that's all of what some of the causes of it. I thought this was a really good picture. I thought this was a really good picture of what a stress ulcer would look like. This is the interior of somebody's stomach, and you can see all those multiple little pinpoint holes that were at one point bleeding sources. And so this is as a result of a stress ulcer. And so that's the key to stress ulcer management is in the prevention of them. And I think I've mentioned to you in the past that everybody in the hospital needs to have peptic ulcer prophylaxis, DVT prophylaxis. So upper GI bleeding, again, I think we've covered that. So obvious bleeding would be hematemesis. If you see coffee ground emesis, it's digested blood, but equally as concerning, melena stool is when the blood is bleeding higher up in the tract. And I just want to contrast that with bleeding lower in the tract, which will be bright red bleeding coming up the rectal area, versus melena, which has that pungent odor, and it actually is this black and tarry, often not form stools, and then occult blood. All stools we send off for occult blood if you're worried with a patient with GI bleeding. And so those stools for occult blood, so there's various ways of taking them. Some of this is just a small plastic container with a little bit of preservative in it, and you just take a little bit of the stool and put it in it. But an occult blood test is really where you have a card and you have two little spots on that card, and you just smear a sample of stool on each of those and send it off to the lab. So upper GI bleeding, as I'm sure you are aware, it is an emergency situation, and so you really need to act upon it very quickly. And so if you saw a patient with either hematemesis or coffee ground emesis or GI bleeding rectally, the patient needs to be managed very closely. And so you would immediately do an assessment, which would include vital signs. And I do what I refer to as a blood pressure that I assess for postural drop. What I mean by that is that I take the blood pressure. This is a sick patient, so I'm going to make sure they're usually supine or semi-Fowlers. So I take their blood pressure, and their blood pressure might be 110 on 70. And then I actually sit them up into high Fowlers if they're stable enough. And if I get if their blood pressure drops more than 20%, then I consider that a postural drop. So if I got a blood pressure of, let's say 80 on 40 as I sit them up, that means they're low in intravascular volume. That means they don't have enough circulating fluid, and that's more of a concern to me. So that's another non-invasive way to check fluid status. And so I'm going to do the vital signs. I'm going to check the pulse to note how regular it is, how strong it is. So when I check my pulses, as you know, I'm checking not just my radial, but I'm checking my distal pulse, my dorsalis pedis, and posterior tibialis. I want to make sure that there's a nice strong pulse in all four limbs to indicate that the heart is as effectively pumping. But if this patient is actively bleeding, the patient is going to be shut down peripherally and have vasoconstriction. So I'm going to check my pulse. I'm also going to check for cap refill of all four limbs. And I'm going to really monitor this patient closely. And as you know, as a clinical instructor, if you're told go and monitor that patient closely, that means Q5 minute vital signs till stable, then Q15 times 4, Q30 times 2, Q1 after that. And you're looking for those early signs of shock. GI bleeding is quite it really is one of the leading causes of hypovolemic shock. And so I really want to, because remember, shock occurs at the microcellular level. By the time I have a change in my vital signs, I've missed all the early signs, and that is really concerning. So I'm going to do my vital signs. I'm going to then do a careful assessment of my abdomen. I'm going to look for any kind of abdominal distension, and then I'm going to listen for my bowel sounds. What do you think you would hear in terms of bowel sounds? Hypoactive or hyperactive? And if you said hyperactive, you are correct. Because remember I said the body doesn't like blood, so it's going to push that blood or that digested blood through the tract very quickly. And so you actually might hear hyperactive. They may be normal, but they also might be hyperactive bowel sounds. The abdomen may be soft and distended, or it may be hard and rigid, as like a peritonitis. The blood work that you would be looking for would be, of course, a CBC. And do remember that I look for those 4 elements because I need to care for this patient quickly. So I need to know what my hemoglobin, hematocrit, because maybe he is really dehydrated. So I want to know my hemoglobin, my hematocrit, my platelets, and my white count. Chances are your white count isn't really that elevated, although it may start to change because of inflammation processes. So you may find it up there slightly. And platelets, you're hoping that they are normal so that the patient has something to help clot wherever that ulcer is. Excuse me. And I want to look at my electrolytes, in particular my sodium, potassium. Want to highlight, we talked about blood products a couple of weeks ago. When you are giving massive blood transfusions, the patient can become hyperkalemic because of the preservative. So if we've been giving any blood, I want to be very particularly looking for my potassium, and of course my sodium, but particularly sodium and potassium. If you have other bloods like blood glucose, other coagulation profiles, they may do a PTT or an INR. So remember, an INR is your international normalized ratio that does reflect your prothrombin status or your prothrombin time. But they use this INR because it's standardized throughout the world. And at one point, for the last 20 years, there was only Coumadin or warfarin as an oral anticoagulant. Now, in the last 5 years, we've had more, but prior to that, it was only Coumadin. And so if patients were traveling or lived in other countries, they would have their Coumadin adjusted, and they didn't have a standardized value. So now the INR is standardized throughout the world. So they would have other coagulation studies. They're going to do liver enzymes. So they want to see, first of all, the status of the liver. Is the liver the actual culprit? And is this liver failure, liver disease that's caused it? So maybe there is some portal hypertension causing it. Or I want to know if the liver is able to manufacture my clotting factors and all needed for coagulation. I also, because the patient may be deteriorating so quickly, they might do a blood gas to determine the pH for the patient. Remember that as the patient slips into shock, the pH will change as it shifts from aerobic to anaerobic metabolism. The other thing is you want to make sure that you have blood in the blood bank. And you've heard me speak about this before. If this is an active bleed, I want to ensure that I've got this patient cross-matched for 4 units of cells right away. And we tend to only use packed red cells. We don't use whole blood. We would use packed red cells. So I want to make sure I've got at least 4 units on hold. I don't want to find out this patient starts to bleed actively and I don't have any blood in the bank. So you want to make sure they're group and screen for, and you have 4 units on hold. And so type and cross matched for 4 units means they've got 4 units sitting right there with their name on them, and that is compatible with their blood type. Versus a group and screen that says Leslie's A positive, and I have lots of A positive in my blood bank here. So it's really important that you have that so you can use it at a moment's notice. They may in fact get a urine sample. That's so low on the priority list right now. They might. Sending any of the samples off for analysis. So if you have stool, they may send off for stool. Although honestly, when you see melena, it's melena. There's no doubt about it. And somebody said, well, maybe it's more from iron. Because don't forget, there's 2 different things. Pepto-Bismol will change the color of the stool, and iron will change the color of the stool. And you can really tell the stool that has been changed due to iron because it's black. It is black. It's formed. It looks chalky almost. Whereas blood that is a stool that is changed to like a melena stool or black because of bleeding, it is like that dark cherry look to it. So you can see in the toilet bowl there is some red elements to it. There's no mistaking melena. When this patient, as with all of our patients that deteriorate, and I think I've told you my little mantra or my little acronym to whenever my patient deteriorates, remember, oh my, you need to get the patient on oxygen if it's warranted. And when they're in a deteriorating situation, I just want to get the oxygen on. I'll deal with it. I'll remove it later, but get the oxygen. You want to get a cardiac monitor, so you can monitor for any arrhythmias, and you want to get an IV going. So, oh my. So in this case, you want to get 2 large bore IVs. Typically when someone's deteriorating quickly, it's 2 large bore IVs. And I believe you've done IVs in your pharmacology course, and so you're going to get large bore IVs. Typically I would just go into the antecubital fossa and just get those in and start the saline. You'll want to get blood going as well. We do give unmatched blood, as you know. If the patient becomes very unstable, they'll give the universal blood, which is O. They'll give that until they can actually get the patient cross-matched. Sorry, I didn't mean to crash that against your ear there. And so we typically would give them a solution such as normal saline. They refer to that as an isotonic solution. It is considered a crystalloid. I'm not sure if you have talked about this in your micro course, and I'm just going to briefly touch upon it. That a crystalloid is a molecule that actually acts to draw fluid. So it's sodium. So sodium is a crystalloid. So normal saline is a crystalloid solution, and I think of that as being salt crystals, crystalloid, and it draws fluid back into the intervascular spaces. So that normal saline ringers, they're actually large molecule, and they would be considered a crystalloid solution. On the other hand, blood products are considered a colloid because they actually will work differently and act as, again, as a sponge. They're large molecules, and they actually will help with circulating the fluid back into the intravascular spaces, um, and they're referred to as a colloid. So sort of drawing that in because of their molecules. So they will give the patient packed red cells, and perhaps even they might give FFP, fresh frozen plasma. They may use even volume expanders, and I'm not sure if those of you on surgery saw Voluvan or Pentaspan. It's like a synthetic albumin. So another large molecule. It's a non it's a like a blood product, but it's a non-person type blood product. So it's a synthetic um, protein molecule, or they call it a hetastarch. And so they give that so that you can give a small volume, but really get that sponge effect. It's going to really draw that blood or the fluid back into the intravascular spaces. So I think I've covered all the things that I wanted to cover about GI bleeding. This patient may also need a Foley catheter. If the patient is unstable, I would put a Foley catheter in, because the patient's not going to be able to stand up and void, and the bedpans are so they're very difficult, and so you won't be able to move them on off the bedpan. So get a Foley catheter in. But more importantly, you want the Foley catheter in so you can measure the urinary output every hour. And you know that an adult urinary output is 1 mil per kilo per hour, or 30 mils per hour. And so you want to get you'll want to have the Foley put in so you can monitor their urinary output. And remember when we talked about stroke volume, or the blood pressure, urinary output's a good indication of having an adequate perfusion pressure. So if you're getting 30 mils per hour and the skin is nice and warm and dry, and you've got nice strong pulses, then this patient is probably has adequate blood or circulating volume. But if you find your pulses are getting weak and thready, it's of great concern, and you'll want to get that patient perhaps transfused, get an order for transfusion. You also want to get this patient onto medications such as a proton pump inhibitor, and we would be giving this patient medication intravenously. So that might be ranitidine IV, or oh, it's not ranitidine. What's the other drug? It's not Nexium, not Prevacid. It's going to come to me in a minute. And so you'll want to get those medications in. Typically, this patient with GI bleeding, they have an endoscopic procedure. And I have to say, one of the gastroenterologists was simply brilliant. We had a massive GI bleed in. It was on a Friday night. He wouldn't be able to be seen till Monday by the specialist. And this one GI intensivist was just happening to walk by the unit on his way home. He said, you know what, let me do it now. This patient had sclerosing by the change of shift, and he was home by Monday. So really the sclerosing was quite effective, and they just go down in with the endoscopic scope, and they just do a little burn, and that creates a little bit of scarring there, but it also prevents that from bleeding. They also can inject medications into that ulcer as well to help it heal up. Not so much that they're causing it to heal, but to stop the bleeding. It's another sclerosing type agent. And please feel free, if you have any questions, and you can put that in the chat feature. I'm just trying to keep an eye on that, so that if anybody has a question, just slow me down and I can answer you there. So, nursing assessment for the GI bleed, as I mentioned, I think we've already gone through some of the vital signs and the nursing assessment of the abdomen, as well as if the patient's well perfused. And then when they are discharged, you'll want to do really, really good health promotion, and we'll talk about that in just a moment. Another test I just wanted to mention to you, one of the causes of the upper GI bleeding, and it could be, as I mentioned, all of those medications, most often medications, it could be those other conditions. One of the other things that has just come to become apparent or come to light in the last maybe, well, I guess I'm going to say 15 years now, is that GI bleeding can be caused by a bacteria. And the name of this bacteria is H. pylori. Helium pylori. So some people have bleeding due to H. pylori bacteria, and in which case they would do a urea breath test. And the way this bacteria lives in the stomach, it has a lot of this. It produces a lot of urea, and so they actually would have the patient swallow a tablet, and then they would test that they breathe into a container, and they would test their breath for the presence of urea. So just that you need to know that sometimes that GI bleeding is caused by a bacteria called H. pylori. The test for that is a urea breath test, and the treatment for that, as with any kind of bacterial infection, is an antibiotic. Nursing diagnoses, and again, I think we've talked about that, nursing diagnoses, that we tend not to use these as much in Canada. I do want to say that they may be on the NCLEX exam, so that's why I sort of put them up there just very briefly, and we don't talk about them, but the nursing diagnoses were they're referred to as a NANDA approved list, and that was just the governing body, and we used to use them many years ago. So it would be ineffective pain management due to ineffective pain control due to abdominal discomfort from GI bleeding. And we used to make these very laborious learning care plans. We used to make our own care plan, so the admitting nurse would make up the care plan and everybody had to follow it. It's quite labor intensive. We don't do that now. We have a lot of clinical pathways, so we don't need to do that. But what happened with nursing diagnoses, and I just want you to be aware of this, is that nobody knew what we're talking about, ineffective airway exchange. So we tend not to do that. We say the patient can't breathe, they're short of breath. So just to be aware that they are there. It is an American acronym. Some schools still do use them. I don't think a lot of the baccalaureate programs do, the PM programs do, but we tend to move away from that because we call it like it is. So I just wanted to put that out there. And anything about, and of course, planning with the patient around what they need to do for their own health conditions. I'm just want to keep an eye on the time here. And so and I just want to highlight, I may go a little bit over, so please feel free just to check out when you need to. So with health promotion, one of the things with GI bleeding, of course, is that the patient gets adequate rest. We don't want to have them under stress producing more stomach acid, so you want them to have adequate rest, both physical and emotional, and we need to keep a very quiet and calm environment. And it's difficult when you have a patient that's vomiting buckets of blood, but you need to create that healing environment. And that's from Gene Watson's Gerdes processes about maintaining that healing environment. And what a difference, even in the midst of a very busy surgical unit, you can really create that healing environment. So don't ever lose sight of that. You want to ensure the patient is aware that they should not take aspirin or NSAIDs, because that would cause gastric distress. Now, sometimes with some of our medications, they have the physician will often weigh the benefit versus the risk. And if this patient needs NSAIDs to function every day, they may put the patient back on their NSAIDs and monitor them closely, a lower dose, and put them on something that's going to coat the stomach, Prevacid or that sort of thing. They're going to get the patient to eliminate smoking, because that can cause irritation of the gastric mucosa, and also watching different food that might cause irritation, some of that spicy food, and not all of it, and caffeine is another culprit. So this is just sort of what we've just talked about in a little bit of in a nutshell here. And so as you can see, you have something that's eroding the gastric mucosa up here, and it causes this breakdown of the gastric mucosa. Remember that the gastric mucosa is like the inside of your mouth. It's like when you get a canker, but it's much more severe than a canker. You get this acid-back diffusion into the mucosa and destruction of the cells. That in itself will, again, cause because you're having increased acid release, it's going to cause more breakdown. You also will get histamine releases with any inflammatory type disorder. And so if you get histamine release, with that histamine release, remember we've talked about it, you're going to get vasodilation of the periphery and increased capillary permeability. So I think of it, remember, and I'm not sure if I told you my story about the TED stockings versus the fishnets. We'll save that for another day. But it means that there's increased permeability. So instead of having everything nice and tight, it's now spread out and all the fluid is leaking out in the periphery. The patient's quite edematous. And they lose a lot of plasma proteins, which again further depletes their serum proteins and causes edema. You also continue to have the erosion causing ulceration. And again, this is just once you have that barrier disruption, the patient who is normotensive, that the blood pressure is normal, you're going to have adequate flow. But if the patient becomes with a decreased blood pressure or ischemic, you're going to have decreased flow to that mucosa, and that's when you're going to get that real opening of an increased capillary permeability. We've talked about all of the conditions that cause ulcerations or peptic ulcer disease. Although, remember, under other factors that we want to add stress to that. Oh, here's physiological stress ulcers, but stress will also contribute to that. Peptic ulcers can cause hemorrhage, and we talked about that, how they can have hematemesis, basins, but also that if the peptic ulcer can cause a perforation, and if it's right at the right part of the stomach, it can actually perf right through the stomach wall into the peritoneum. And as you can see in this picture here, how this is the duodenum and the ulcer is now just eroding right through. And so complications from peptic ulcer disease, and I think we've talked about being hemorrhage and perforation, but also as we've talked about is that with that constant irritation, etc., you can also have scarring left as a result of having these multiple gastric ulcers, and that can cause a gastric outlet obstruction, prevent emptying of the stomach. We've talked about we've talked about the collaborative therapy, which is really very it's conservative or symptomatic. We've talked about all of the different medications that you will give to the patient with peptic ulcer disease, and those are all given very commonly. These again are the medications. I'm going to say that Lake Ridge Health gives Prevacid to all their patients every morning. We also we don't really have Nexium here in Canada. I'm sure it's coming. We give Pantalog. That's the medication I was saying, Pantalog, intravenously. We don't give as many of the anticholinergic medications that we once did. Okay. We've covered peptic ulcer disease in a nutshell. I hope you've been able to complete a concept map from what our discussion has been, or even in your mind, just sort of start to see the patterns of what are the clinical manifestations, what are the risk factors, what are the common medications, what are the diagnostic tests, what are the nursing and collaborative interventions, because we don't work independently. We always work collaboratively, and so we may need to get an order for some medication. And then what are the complications that we're really trying to prevent? And so start to think of it in those sort of patterns. So now we're going to move on to abdominal pain. Abdominal pain. The abdominal pain can be caused by a number of different conditions. And so the most important thing is that you are assessing the patient with abdominal pain, because you don't know whether it's a bit of crampiness because they haven't had a bowel move in a couple of days, versus is this a dissecting aneurysm? It's really hard to discern. So the first thing you want to do is you want to assess the patient. We always start with our assessment for anything, and do remember that you're going to do your assessing your primary survey ABCs. The only time that you're going to do that differently is when the patient is unresponsive and in a cardiac arrest. So unresponsive and pulseless, in which case you're going to do CAB. So you're going to assess your cardiac status, they're unresponsive, you've already determined that they're pulseless, they're not able to protect their airway, and they're not breathing. So you're going to begin CPR immediately. But basically, and that's a good strategy for writing your tests as well, is to look at the answer in terms of, well, where is it in the ABC continuum? Well, it says the patient's talking. After speaking to the patient, okay, then I'm on to breathing and circulation. So looking at your ABCs, want to check the blood pressure and assess whether the patient is adequately perfused. Is the blood pressure greater than 100/60? And again, I want to just remind everyone that that is very contextual, because if that blood pressure is normally 140 or 150 and my pressure is now 100, I am concerned. I'm going to assess the heart rate, looking for a heart rate that's typically the normal, and looking at the trend. Do remember that as the patient becomes more hypovolemic, as the blood pressure starts to drop, the heart rate goes up as a compensatory mechanism. And so you're going to find that increase in the heart rate maybe by 10 beats. And I think I've mentioned that before, that the normal heart rate is going to be 72, has been that way for the last 36 hours. And all of a sudden you've taken it, it's now 84, 85. So I would be concerned that this patient might be hypovolemic. They also might have other causes. They might be having pain, or they might be febrile. But I'm going to make sure that they are, they have adequate circulating volume. They may have an elevated temperature to indicate it's an inflammatory process or an infectious process. So it might be a infected diverticulum or peritonitis. The abdomen should be inspected for distension, masses, abnormal pulsation, rashes, or any kind of other changes. And so remember, this is the time you want to get right down at the eye level and look at that abdomen. Is it round and protuberant and distended? Is it hard and firm and tender? Or do you actually see a pulsatile mass to indicate that it's a dissecting aneurysm? Is there a rash present? And don't forget to look along the flanks as well. So you're going to do your inspection. This is the time you're going to do your auscultation, and you're going to place your stethoscope in all 4 quadrants, listening for 15 seconds to see if there's any bowel sounds. And then if warranted, you're going to lightly palpate the abdomen, avoiding the painful area. So once you've done your assessment, your vital signs, and now you've done your focused assessment, then you're going to really, and you always begin with doing your subjective inquiry as well. And we've talked about doing a PQST format. So you're going to do your subjective inquiry. Typically, it's done simultaneously as you're doing your objective inquiry as well. So with acute abdominal pain, it can be caused by so many different things. And I just want to highlight that the abdomen has many hiding spaces. For lack of better words, the abdomen can hide a lot of blood, or a lot of pus, but a lot of blood, and it not be visible until you see this really big, huge belly. We have this retroperitoneal space that's quite an open area and can consume a lot of bleeding. One of the cases we did a femoral catheterization. So patient went to the cardiac cath lab and had a femoral access, and somehow this patient had continued bleeding into the retroperitoneal space. And so we could see that the patient had a bit of bruising along the flank, and of course the vital signs were changing. So always looking for those areas where looking to see that this might be a potential bleed. Of course, it's quite obvious when they have like a stab wound to the abdomen, or a gunshot to the wound, to the belly. Those are quite obvious. Acute ischemic bowel injury. Oh my gosh, bowels can become ischemic and gangrenous very quickly. Sometimes it's what a twist in the bowel, or a volvulus is the other word for it. Or it could be what they refer to as an intussuscession. So the bowel actually sort of goes in on itself. I'm trying to think of, those children's toys or those swords that they are about this big and they fold all in and then they pull them all out. A telescope is what it is. It's like a telescope. Of course, appendicitis, blunt trauma, bowel obstruction with perforation. So you get this and this massive dilation, and they refer to that as a megacolon. They get this massive dilation. Of course, if you think of this area being like a balloon that's blown up way too much, it's very, very, very thin, it can rupture. And then you end up with stool in all of your peritoneal space. Cholecystitis, Crohn's disease, foreign body. You can have injury to the mesentery, so you can get a thrombosis, so a blood clot traveling to the mesentery and causing a mesenteric thrombosis. Pelvic inflammatory disease. I want to just highlight that if any female of childbearing age presents with abdominal pain, the first question I ask is, when was your last period? You need the date of the last menstrual period to ensure that this is not a ectopic pregnancy. Women are still dying from ectopic pregnancies, so really important that you ascertain what is the date of the last menstrual period. It could be as pancreatitis. Pancreatitis is very, very painful, and I think, did we talk about it last week? I think we did talk about pancreatitis briefly. It is very, very painful, and so that can, and again, we treat them like an acute abdomen. A ruptured aneurysm, so they could have this tearing feeling in their back, and if someone says to me, oh, I've got this horrible tearing feeling, I'm concerned that it might be an aneurysm. So they may have this ruptured abdominal aneurysm, a tearing feeling, and I think those are the ones I wanted to mention. They also might have acute abdominal pain due to colon cancer. So just if cancer is located in the transverse colon, the pain, you might feel pain. There might be also obstruction or narrowing, and that's when the stool becomes very ribbon-like. You'll see a change in bowel habits, and the patient might also be anemic. If the mass is in the ascending, or the cancer is in the ascending colon, you may find, again, pain in that sort of right side of the abdomen with a change in the bowel habits. The descending colon, a little different. There's bright red blood in the stool because it's now, the stool is already formed by the time it gets to the descending colon or to the rectum. And so you're going to find that blood may be on the external piece of the external stool, or it might even be a little bit mixed into, but it's still very formed stool. And as it moves down into the rectal area, they might even feel this real intense pressure. And so just another flow chart of what happens with acute abdominal pain. And so it's broken down into sort of inflammatory processes, peritonitis, it's also inflammatory or infective, obstruction, mechanical obstruction, and internal bleeding. So as you can see, the end result is, of course, very concerning, and we need to prevent either septic shock or hypervolemic shock. Both of those are so, they're once they get to that shock trajectory, it's very concerning that they may just continue, because remember that shock occurs at the microcellular level first. So they've already started that altered metabolism. The cells are using other sources of fuel, and they're not metabolizing correctly. Patient is becoming more acidotic. We know the heart doesn't like to work in an acidotic environment. I think that's all I really wanted to mention. I think we've talked about everything. Clinical manifestations of acute abdominal pain. And again, we've talked about that it's really, when you're doing your assessment of a patient with abdominal pain, it's sometimes very difficult. So you need to really look at the PQRST, doing your subjective inquiry very, very closely to find out if there's some kind of a pattern. to find if this is a new type of pain. Also looking at the associated findings. And I don't know if I shared with you that I always add on the PQRST, of course, the U, what is the patient's understanding? What do you think is happening? But also I want to find out about, add 3A's. So associated findings, alleviating, and aggravating. So is there anything else that's accompanying this pain? Are you nauseated? Do you feel cold and sweaty? Are you vomiting? Does anything make it better? Yeah, once I vomit, I feel better because there's no pressure. Everything is gone, or the anti medic works. And also associated, alleviated, and aggravated. What makes it worse? Well, when I lie on my right side, it's worse. So really looking at and doing a thorough assessment. Diagnostic tests for people with acute abdominal pain. So again, I want to find out I want to get my CBC, my electrolytes, urea, creatinine, liver function. I want to get a glucose because I don't know if it's pancreatitis. Liver, I want my liver function. I also want to do a coagulation panel. The patient, depending on what is the underlying, what is the problem, the diagnosis, patient may require some urgent antibiotics. And they might even put in an NG tube. An NG tube can be put in for a variety of reasons. So a nasogastric tube can be put in for decompression of the stomach so that they're not vomiting, potentially creating a Mallory-Weiss tear. They're not vomiting. It also helps them feel more comfortable with this removing and decompressing the stomach. But also you can use that NG tube for providing them medications, and in future, if they needed some feeds, you can use that same NG tube for feeds. And I'm going to talk at the end of the presentation about care of the NG tube. I just want to make sure everybody's on the same page with that. So with a patient with abdominal pain, you'll get an order for, of course, IV fluid. They need that fluid volume replacement, and you'll find that it may be quite a large amount. So it's not going to be the 50 or 75 an hour. It might be 150 or 200 an hour because they can become hypovolemic quickly. So again, cautiously giving fluids to the older adult. I monitor their breath sounds quite closely. I want to know as soon as they start to sound like they're going to fill up, I'm going to get that order DC'd. You may, so getting the patient intravenous, it's going to be large bore, perhaps even antecubital. The patient will be NPO for whatever the underlying diagnosis is, but also until bowel sounds return. You don't want to be giving fluid and having it sit there in the stomach. So if they're NPO, they may not, and they have no bowel sounds, that means nothing's traveling through their gut. So it's going to just sit there, and then they're going to wait. They're going to vomit it. So you're going to have an NG tube in to help reduce some of that abdominal distension. I just want to also highlight that I've received orders to administer the IV rate. So I might be giving my IV at 100 per hour plus the NG tube replacement. So my NG tube may be draining copious amounts because it's not just all the mucus, but it's also all of the, how we have that our body's constantly making additional fluid, and we have that insensible loss and a lot of gastric content. I think, what do they make? 1,200 mils of gastric content every day. And so if that 1,200 is not going anywhere, it's irritating. You're getting more mucus production. You got the stomach, the bowel sort of backing stuff up. So you can have a lot of GI loss. And so sometimes I've had an order where we've replaced the GI loss every shift. And so if I finish my shift, I take out my tallies, what my intake is, my output is, and then my NG loss. If my NG loss is 500 mils, then I'm going to report to the next shift that you need to replace 500. So they would take that 500 and infuse it over the next 12 hours, whatever their shift was. I might, if there's a large amount, they may order me to actually replace it with the IV hour per hour. So I would just merely say, well, yeah, 200 that hour. So I'm going to infuse my 100, the maintenance, and then another 200 for the NG loss. So really monitor the patient's fluid status very closely. They may give antiemetics if they're vomiting. Gravel doesn't tend to work. I'm just going to tell that right up front. Gravel tends not to work. They give it intravenously. And so you may find you need to move on to other antiemetics. One of the newer ones that was restricted in use at one point to just patients with cancer is Zofran or ondansetron. It's quite expensive. I find they're using it a lot more because it actually works on the emetic center in the brain, and it stops that vomiting, and it's quite effective. So they're going to get the patient prepped if this is a bowel obstruction, a ruptured diverticulum. They will perhaps require some kind of a surgical intervention. And so they're going to prep this patient for surgery. Of course, the patient will be NPO preoperatively. They've got their IV established. They've got all of their OR chart ready. Their consent is ready. Any of their belongings are secured, their teeth are locked up, their contact lenses are removed. The hearing aid is with the patient so they can hear the instructions during the surgery. Then they will go down to the OR prep and hold area where they'll go through another secondary checklist in that the doctor, the OR nurse, and the patient all agree that this is where the surgical site is. And then when they've had the procedure, I just want to caution everybody that after having a big abdominal procedure, their bellies have been open for quite a period of time. They've lost a lot of fluid yet again through that insensible loss. And also they may be, their temperature may be very low because they've got so much exposed so the surgery can be completed. Unless it's a laparoscopic chole or a laparoscopic appendectomy where they do it through a tiny keyhole and they do the work. It reminds me of when you go to the exhibition and you know those games where you play with the little knobs and you have like a little clasp, some kind of a claw that grabs the stuffy down in the machine, but you're working. That's what the keyhole surgery is like, or minimally invasive surgery. And so you'll find these 3 little spots on their belly, or depending on the type of surgery that they've undergone. Unusual post-operative care. So again, early mobility, pain control. This is a patient you're really going to have to watch their fluid status because they're already a little bit dehydrated. So watching their urinary output and replacing any NG losses. Abdominal trauma. Moving on to abdominal trauma. And so abdominal trauma, and again, we're seeing this a lot more. When I think of abdominal trauma, I think right away of stabbings, gunshots, a car accident with seatbelt injury. So quite severe type injuries. So it could be a blunt trauma or it could even be a penetration, as I mentioned. But there is damage to the abdomen, and you're hoping to minimize any damage to adjacent organs, liver, spleen. Oftentimes in a motor vehicle accident, you may even suffer a lacerated liver, a ruptured spleen. They could have arterial tears from impact. They can have the bladder rupture as well. So if their bladder is distended and on impact, they may actually tear the bladder. They can have renal injury. Most often, I would see most common ones would be a contused liver, a ruptured spleen. I don't think I've ever seen actually taking care of a patient with a ruptured bladder. But a lot of seatbelt injuries. So their bowel is actually bruised because of seatbelt injury. Signs and symptoms of abdominal trauma can be that the patient guards or splints. So their bellies are going to start to get firm because of the inflammation or bleeding, and so the patient starts to guard. So they're not moving; they're holding their bellies. They may have decreased or absent bowel sounds. You may actually start to see, bruising from the seatbelt or other instruments. I just want to highlight that you look to see the flank, because sometimes you see bruising along the flank or bruising around the umbilicus, which means that there's bleeding into the peritoneum. What else I want to mention? severe pain. You also might find that this is a really odd thing. You get this, what they refer to as shoulder tip pain. So this is pain over like in the scapula or under the arm, or like right under the shoulder here, caused by irritation of the phrenic nerve by free blood in the abdomen. So I'm always nervous when I hear someone saying I'm like a shoulder tip pain. My shoulder's sore, but there's no evidence of injury. There was no seatbelt there. They might have hematemesis. They might start to vomit blood, or they might put out blood in their urine, hematuria. They also, as I mentioned, they may have some bruising around the umbilicus. They call that Cullen sign, and I sort of remember that because it's a C around the umbilicus. So I draw a C around the belly button, which can indicate retroperitoneal hemorrhage or abdominal hemorrhage, particularly if it's ruptured ectopic pregnancy. So I look to see for that Cullen sign. Or that bleeding around along the flanks. So nowadays they would, of course, send off stat blood work right away. So that would be CBC, electrolytes, urea, creatinine, glucose, liver enzymes. I want to know if there's any contusion. I'm going to send off urinalysis, and then they'll probably do some kind of a scan. We used to send them off to the X-ray department, but right now the part of the diagnostic panel is doing ultrasounds, and so they'll quickly do a trauma ultrasound to see if there's any evidence of bleeding. They also used to do a quick laparotomy right in the OR to see if there's any free blood there. So they just pop in a little scope to see if there's any blood, and then they'll know which OR to put them in. We don't do peritoneal lavage anymore. We use ultrasound. Everyone's becoming quite sophisticated with the ultrasound machine, and in fact, I'm going to really include that in my high acuity course. That I think that is being proactive, that we do ultrasound as part of the diagnostic panel. We used to monitor cardiac output in different ways, and now I think that the easiest and non-invasive is to do an ultrasound. They're going to look at fluid, that they're aspirating this fluid from the belly to see if there's any blood in it, or feces or other abnormal elements, just to see what has exactly happened. But most important, they're going to focus on their ABCs, which is your airway, breathing, and circulation, making sure that their vital signs are maintained stable. Remember that golden hour, and that is so true. We need to keep the patient fluid replaced, fluid resuscitated, so that they don't deteriorate into shock. And so talked about the laparotomy, and I think that's pretty much the abdominal trauma. Moving into inflammatory bowel disease, IBD. I think everybody knows about IBD. All the commercials are on IBD for medications or for locating washrooms in Toronto. So IBD is really an inflammatory, it's an umbrella term used to refer to as an inflammatory bowel disease that is an autoimmune disorder. And it refers to predominantly two disorders, one being ulcerative colitis and the other being Crohn's disease. Both of them are characterized by idiopathic inflammation. So there's inflammation from some unknown reason, and it causes ulceration. And it's often multifactorial in multiple causes, not just genetics. Quite often you're going to find that Crohn's disease and colitis, they're often diagnosed early in the teenage years, which is, my heart goes out to these young folks that are suffering with IBD. They're totally embarrassed. They don't even want to go to school. And one of my colleagues, her son was troubled by it, and very incapacitated. He withdrew socially because he didn't want to be seen, going to the bathroom all the time. The teachers would actually give him a hard time. What are you going to the bathroom for again? And you have to explain it all. It was really a difficult time. And he suffered like that for about 3 to 4 years. It built up, but really he was suffering and he wouldn't go out of the house. Finally, his doctor said, well, then let's do a colostomy. He had a colostomy and his life was renewed. He was able to go out and enjoy himself. He was out at parties. He was back to his old self. So I feel for these teenage and the young adults who really experience that loss of self and identity crisis with this disorder. So it occurs in the young adult, and then you may see another secondary peak in the early 70s. More prevalent in industrialized regions of the world. You don't see this ulcerative colitis or Crohn's disorder as much in other countries. You're going to see that more in the industrialized regions. And again, there's a genetic predisposition, as I mentioned. And with both of these IBDs, life becomes this pattern of exacerbation for whatever reason, stress-related, medication. You have these exacerbations, and then they go through these periods of remission, exacerbations, and so this is how their life is. It's quite upsetting for these young folks. Very unpredictable. I was quite surprised that in, I think it was 2014, that there was 10,000 new cases of IBD diagnosed in Canada. Hard to believe that there was that many people diagnosed with IBD. And so with ulcerative colitis is a chronic bowel disorder that's characterized by inflammation and ulceration, particularly confined to the rectum and the colon. And so I always envision that from the rectum you have this superficial inflammation, and it's like all those little black dots from the ulceration. This inflammation is diffuse and involves just the superficial layer, so the mucosa, and perhaps a little bit of the submucosa, but pretty much it's superficial, and it starts to travel up the colon or ascends up the colon. The mucosa becomes very red and edematous and inflamed, and and so this is what creates all of the stools, is this red, inflamed, and mucousy stool. Excuse me. And so I just wanted to highlight with ulcerative colitis and Crohn's disease. So this is ulcerative colitis, and as you can see here where my arrow is, that it starts at the rectum, and it gradually just through a series of remissions and exacerbations, you're going to see a little bit more of this inflammatory process, superficial. As you can see, it's all ulcerated. It's a roughened surface, lots of mucus production. It bleeds easy. That tissue is very friable. And so as it ascends up the colon. Conversely, or compare this to Crohn's disease. And Crohn's can be anywhere in the GI tract, and they have what they call skip lesions. So these skip lesions, as you can see, there is one in the bowel, but it's throughout the entire GI tract, and these skip lesions are sort of, you can see where it's sort of pinched here. These areas where it's pinched up inside. So you're going to have normal bowel, pinched up Crohn's, normal bowel, pinched up Crohn's. And in those skip lesions, those areas of pinched up Crohn's, that goes through all the thicknesses of the bowel. So all surfaces, it goes right to the very basement membrane. And we'll talk about that in just a minute. But just to give you a picture of what you're looking at, and so with ulcerative colitis, I'm just going to check and make sure I'm still on time. With ulcerative colitis, as I mentioned, it's an inflammatory process, and it starts with this bloody stool, bloody diarrhea, and abdominal pain. Maybe a little bit of cramping initially. And then it becomes more pronounced and has more discomfort. They can end up with what they refer to as this toxic megacolon. And so this is when this toxic megacolon means it's inflammation, the bowel gets really stretched, and then it potentially could perforate. With mild disease, the diarrhea may just be 1 or 2 stools a day, but when you get quite advanced, you may see up to 20 stools per day. And with that 20 stools, you're losing your fluid and electrolytes, you're losing blood, and the patient becomes very fatigued. They may even have a low-grade fever, malaise, and as I said, more bleeding. I actually cared for one of my earlier patients in the ICU. Was a patient with ulcerative colitis who had these frequent bowel movement, bloodied, and she was a bit anemic, but because of the fluid loss, she actually had an electrolyte disorder, and she seizured. So we always have to, you're thinking, well, this, this is pretty mild. No, this can be very serious because of the fluid loss. And if they become, if they perforate, then it's an urgent surgery. So as I mentioned, the colon can become quite dilated and quite thin and friable. So when you have a really big dilated colon, then it's hard for stool to pass normally. So not only do you have the diarrhea during your exacerbation, but even during remission, your bowel gets really quite inflamed. And so I just want to make sure everybody can hear me there, so I don't want to check that. So they may need to go for surgery right away for a colostomy. The big thing with complications of ulcerative colitis is that this patient is at higher risk of developing colorectal cancer. So if they've had it for greater than 10 years, they're at a really high risk of developing colon cancer, and so need to be monitored quite closely. Also, because there is an immune element to ulcerative colitis, that there is a tie-in with a disturbance of the immune system as well. They may also experience inflammation or inflammatory changes in their joints, in their skin, in their mouth as a result of this overarching inflammatory response. Labs and diagnostics, well, of course, you want to make sure that you have your CBC, hemoglobin, hematocrit, your platelets, and white count. You're looking at your electrolytes to make sure that they're normal, that you don't want to have a low sodium so that the patient will have a seizure. They may have an elevated white count due to the inflammatory response, but also they might have an underlying infection or a peritonitis. You want to also be closely monitoring for protein loss, so you might want to do serum proteins. The way it's diagnosed is through a direct fiber optic examination, such as a sigmoidoscopy. They also might do barium enema. They call it a double contrasted barium enema. So we talked about the barium swallow. This is at the other end of barium enema. They do an enema just like a regular enema. And they put in, 500, 700 mils of barium into the rectum, and they just watch to see if there's any polyps or anything such as that. Because when you're doing it direct fiber optic, because of all the folds, they may not see everything, so the barium will help to fall into all of those folds and will identify anything. So the double contrast pieces, they actually inject air into the rectum as well, and so they look at the barium. Could I just remind everyone that if you are doing a barium swallow or a barium enema, that the patient receives a laxative to help move that barium, because barium will turn to cement if it's not moved out of their GI tract. So sometimes the barium swallow is given in sorbitol that will help as like a laxative, but just make sure that they're passing barium. And of course, they're going to report that their stool is white and pale, and that's the barium moving through. With surgery for ulcerative colitis, that they will perhaps go on to needing some surgery. And so they do a total proctocolectomy or a colectomy with a permanent ileostomy. So they're going to have the stool as well as they're going to have the stool coming out at the ileum, or they're going to do a proctocolectomy and have a reservoir. So that bowel, then the stool will fit in like in a pouch, and then that pouch can be evacuated by an enema every couple of days, or the patients will actually just evacuate it into the toilet. I want to highlight that the drug therapy for ulcerative colitis to sort of help decrease that inflammation in the GI tract is a drug called sulfasalidine is the drug of choice. And of course, nutrition therapy is so important. They need to have adequate nutrients and vitamins. And these patients may not be able to even tolerate. They may be required to go on to TPN, or total parental nutrition. That's just they're creating the pouch. So Crohn's disease. Moving along to Crohn's disease is another chronic IBD of unknown origin that can affect any part from the mouth to the anus. So it can be anywhere in the GI tract. It can be equally affects both men or women. And Canada actually has the highest rates of Crohn's disease. So the etiology of Crohn's disease. What did I want to mention about Crohn's disease? It's very similar to colitis, and so they have these skip lesions, as I mentioned, that could be anywhere, as you said, from the mouth to the anus, and they have these areas where you're going to have healthy GI bowel, and then you're going to have these pinched areas that are the skip lesions where the disease goes right through to the basement membrane. The clinical manifestations are very similar to colitis. You're going to have abdominal cramping. You're going to have perhaps fever and malaise. There might be bloodied stools, but typically not as bloody. Colitis would have more bloodied stools than Crohn's disease. Complications, again, fluid loss would be a big complication. It could also cause perforation. Collaborative care, drug therapy, nutritional, and surgical we've talked about. And so you would do a same as colitis, a colostomy. So Crohn's disease, so indications for surgical therapy, and again, we mentioned perforation. Severe disease, they might want to remove that piece of the bowel. And really trying to help that patient relax and rest. That's really the most important thing. Making sure they have their medications. If they have any perianal fistulas that can happen with ulcerative colitis, then they will need some special care, making sure that stool is removed and that area is kept nice and clean. We've talked about Crohn's. Yeah, I think that's all I wanted to say about that. This is a good diagram, knowing that there is a higher incidence of colorectal cancer. Some areas it's higher in men than women, but pretty much it's the same, like 23 to 25% in the colon. It's not a lot, but as you can see, the sigmoid colon has a higher incidence of cancer than, say, the cecum or the descending or transverse colon. And so I always, of course, ask myself, why is that? And I wonder if it's because stool is evacuated up in the tract. It's much looser, so it moves through the tract, whereas in the sigmoid or the rectum, it's sitting there for prolonged periods of time, and that can become carcinogenic right there. Let me just see if there's anything else I want to mention about cancer. I think that I did want to briefly touch about cancer, because we do have some of our students going to the oncology area, and you're going to find that colorectal cancer you'll find a lot of patients with colorectal cancer. It is the second most common cause of death in cancer, is colorectal cancer. The incidence of colorectal cancer specific, as we've looked at, it varies from site to site. And what else I want to mention? Typically, early signs of cancer, and as you see the risk factors there, the early signs of cancer is not pain, and so really it's a change in your bowel pattern. So patients really need to embark on a very stringent screening protocols, and they send off stool for occult blood early. Those are all part of the screening protocol. And I don't know if I mentioned this to you, but one of my friends had sent off stool. He was 50, and they do send off stool for occult blood as part of their screening tools. And they call that, the acronym is FOB, stool for occult blood. And so he actually got the specimen. He was most embarrassed to do it. He got the specimen, and then when he was actually addressing the card, because you send it into the lab to be identified, he addressed it to himself. And so he ended up with the stool sample returned to him. He never did it again after that. So hopefully he's having other methods of being screened. So that's really, and here's some more pictures of cancer. I mean, as you can see very clearly how destructive it is and how important it is to have early screening. You can see in this diagram here, these are gastric mucosal polyps. As you can see, I think there's another polyp over here as well. What else do I want to mention? This is actually the rectal area, or the cecum of the cecum rather, and you can see the cancer. This whole cancer. This bowel is all cancer, but it hasn't caused obstruction yet. So as cancer advances, you will get pain. There's mass. There's change in that. You can actually palpate a mass or see it on a scan. And tests for colorectal cancer, again, they often will go to the report to the doctor that they've had a change in their bowel habit. They used to go every day, every second day, and now it's once a week. They're maybe feeling a bit of pressure in their lower rectal area. They might even have pain. They might be complaining of pain, and so then their family doctor will then first of all do a digital exam, refer them to the gastroenterologist for perhaps a sigmoidoscopy or colonoscopy. They'll have that barium enema, as I mentioned, and then they'll have lab works drawn as well. And we've talked about CBC, electrolytes, urea, creatinine, liver function, and they might go on to have a CT scan of their abdomen. If in fact it is cancer, they will take them for removal of some description, whether they remove the entire colon, whether they remove part of there's some very massive big procedures that they will do to remove the cancer, and including the bowel as well. So they might need to do a hemicolectomy, a colectomy. They would maybe need to do a colostomy, could be temporary or permanent. And then following that, they may need to follow up with local radiation to kill off any tumor around that, and or chemotherapy, a 6-week course of chemotherapy. What else do I want to mention here around chemotherapy? I don't think that there's other agents, and we're becoming more sophisticated, although I do see medications, I mentioned it to you last week, where we actually had to mix up all of the anti-neoplastic agents and how hazard that was for our health. But a lot of the agents are the same, have been around for 40 years. And so I'm thinking now that we're going to see more medications, more anti-neoplastic medications hitting the market. I haven't seen that, but what I have seen just recently is that targeted therapy. So they actually take the agent, they take the tumor and they take the agent, and they studied it in a laboratory setting, and they make sure that it's just like a culture for CNS. They make sure that anti-neoplastic agent will be effective against that tumor. And if you recall, Rob Ford, the former mayor of Toronto, had that targeted therapy. So I just, that's something that's on the horizon. We don't do that. It's common. Um, Nursing management for someone who has cancer. Again, you're dealing with an abdominal situation that you need to do, be an expert surgical nurse, but you're also dealing with an oncology situation with a patient that has heard the C word. They feel that they've been given a life sentence, and it's quite tragic. And so you need to be providing a lot of emotional support for the patient and the family. Answer any of their questions. Preoperatively, you may want to invite we have the enterostomal therapist, the enterostomal nurse come and speak with the patient. The enterostomal therapist is a nurse that specializes in colostomy care and wound management, and they are just so gifted at getting that appliance to stick to that person's belly. One of our fourth year students had actually asked to do a placement with the enterostomal therapist because they were just so brilliant at getting these appliances to stick, fixing wounds, etc. So really, perhaps inviting the enterostomal therapist to come and assess the patient and help them with learning their own self-care. What else I want to mention in terms of preparation? I think that's about all. It's really post-operative care will be really around assessing post-operative stability, of course, so monitoring them very closely, but also that stoma. The stoma should be always nice and pink and healthy. It should look like the inside of your mouth. If the stoma looks purple or dusky, or you're concerned that it might become ischemic, which means there's no blood flow to it, and it can actually become necrotic. So you want to make sure that you avoid that, and that's reported. Those are actually quite good test questions, so that you want to make sure that the stoma is pink and healthy and protruding about an inch and a half from the belly, the abdomen. You want it to be extended a little bit. So if you have this, so you want it to be extending off the belly a little bit so that you can put the appliance around it. If it's flush with the abdomen, it's very hard to get that stool to flow into that bag. You want to make sure that the sutures are intact around. It's not dehiscing from the wall of the stomach. And you also want to make sure that it's not telescoped into the bowel. That's another situation. So it can either herniate and fall out, or it can actually telescope in, and you don't want that either. You want to report that right away. And so, but you also want to make sure your appliance is right up to the edge of the stoma itself. You don't want it to be too tight and strangulate it, but you want it to be right up so that the stool will flow and the skin around is protected. Guard that skin around it very carefully, because once that starts to break down, it's very hard to get an appliance to fit that. So really making sure that that is kept protected, and that the colostomy, you don't want it to get more than about a third to a half full. You want to empty that pretty often. So you have like a drainable pouch at the bottom. You just empty that. It could be into the toilet, into a container at the bedside, or in the bathroom. It might have a foul odor, and we do have some deodorizers that you can actually stick right inside the appliance that will help with that smell. You want to make sure that just counsel the patient to wear loose-fitting clothes initially, because they're so embarrassed. And they're actually, if swimming is part of their exercise regimen, there are some devices that you can cover this colostomy with that will permit them to swim in the pool again. So we really do have to know our patient. So I would get the patient, I would show them how I was doing colostomy care, and showing them what I was doing, then I would actually get them to do it so that I could supervise them. Different types of colostomies, and I don't know if I've got my next diagram here. So I guess that you would tell in this diagram. So that's another good thing to just sort of make note of. What type of colostomies would you be seeing? So if you had a colostomy in the ascending colon, in the ileum, or the ascending colon here, it's going to be quite loose because the water hasn't been reabsorbed. Whereas something in the lower tract, in the sigmoid, down in the left lower quadrant, is colostomy emptying out the sigmoid, more water's been absorbed, so it's going to be more form stool. And this Coke pouch that they create is a reservoir that the patient can actually empty, so that it's a totally continent ostomy. The double barrel. So this is quite dramatic. This double barrel. What they do is they pull up the bowel, and so they put they put a rod in there. Please don't ever remove any kind of rods. I know you wouldn't, but the rod's only, the physician's the only one that really takes the rod out. So this is a good picture to make note of, that the colostomy is in the lower part of the ascending colon. So they'd find that on the right side of the belly. They would have more fluid and water. There would be looser stool. As with the ileum, it would almost look like yellow water. This would look like particles of form stool, like little bits of particles in like a soup. And then when you get more into like the sigmoid, it's going to be very formed stool found in the left lower quadrant. So this is how a colostomy looks, and how it has to protrude from the abdomen. As you can see, it comes out. You want to make sure you have that sort of a protrusion so that you can put your appliance right on top of that. Again, this is just different locations of what they're doing. And I do want to highlight that what sometimes they'll do with colon surgery is that they will do the surgery and they'll do the surgery in 3 pieces. So if somebody comes in as acute abdomen, they're obstructed because of a tumor, they'll actually just decompress the abdomen. So we'll take them to the OR. This patient is sick, febrile. They don't want stool spilling into the peritoneum, so they're actually going to take them to the OR. They'll cut the one end of the stool of the bowel, bring it up to the surface, and just decompress the rest of the bowel for 4 to 6 weeks. Then they'll take them back to the OR. They'll remove the tumor, clean it up, and let the bowel heal. And then within the year, they will do an end-to-end reconnection. And they call that reconnection an anastomosis. So they'll do an end-to-end anastomosis. For ostomy care, I think we've talked about preoperative care. We've talked about postoperative, very typical type of postoperative care. I think we've talked about colostomy care. Again, there's many different products. Get the interested nurse in to help make recommendations. There's many different products that can be used, and just ensuring that the skin is kept cleansed and intact. I think that's really all I want to say about the colostomy. The other thing that you want to make sure is that they need to adapt to an ostomy. So that you might just give them a mirror so they can, are you ready to look at it today? No, I don't look at it. Okay, that's fine. I'll take care of it. Maybe tomorrow you'd like to have a look. Let's just deal with today. No, I don't want to look. Do I look so just really giving them opportunity. And if they don't, that's fine. Sexual dysfunction after ostomy surgery. And again, that is a really big consideration. A lot of our, I used to do an exercise, or I have in the past done an exercise where all the students wore a colostomy for 2 days, and again, it really affects your view of yourself. It really, when you think, when somebody said, well, I couldn't put it on because I had to go to the gym, and then I had to go to a party Saturday night, so I couldn't do it then, and then I couldn't do it that day because I had to go out, and so, but these are people that have to live with it 24/7, and so they really find it difficult. They might experience rejection because of this, and I think one of the comments that I've heard is that the spouse said, "Oh, I would never have sex with you with that." So important to help that counsel that couple should they need counseling, referring them to other clinics if they have issues around sexuality as a result of the colostomy. One of my another friend, which again I would have never thought about. This is not in the Lewis book. These are the things you need to know but are not written. So he had a colonoscopy and ended up with the complication of a rectal perforation because of the colonoscopy. He had the 3-part procedure done. He had a colostomy for a year. And what he said happened is that when he would be at night, of course, with all the blankets, he got warm. His partner would be up close to him, and the bag would actually come off him and go onto her. And so these are the things I never even thought would have happened. And so, again, That was a real embarrassment to this couple, and so that you might want to consider putting like a tube top over that colostomy at night, or put a pajama over it so that it wouldn't melt off and onto something else. So just these things we need to help troubleshoot. We've talked about we talked about care of the ostomy, and again, as with all of our patients, it's all around dignity. It's really ensuring that we preserve the dignity of this patient, and the patient is able to carry on with a dignified life. Also, is the cost. The cost of these things are quite expensive, and this is on an ongoing basis. I just purchased them once a semester, and I thought, wow, that is so expensive. So really being aware of these sorts of things, and maybe needing a social worker. The other thing is that dietary, you might want to instruct them on diet so that they don't have a lot of gas. So not a lot of gas creating vegetables, cabbage, raw fruits, vegetables, popcorn, nuts. They might want to just gradually start to see how if they produce a lot of gas with that. The other thing I just wanted to touch base as we finish up is around NG tubes. So after surgery, of course, they're going to have an NG tube placed. Please be mindful of your NG. I'm not sure if anybody's trying to chat to me or not, but where's my chat feature here? Oh, no. Okay. But I just wanted to quickly remind everyone about their NG tubes, that an NG tube is placed through the nair. Make sure you're doing nair care. And I might even take a Q-tip and clean it, or at least get a face cloth and really wash well, because there's a lot of encrustation. And one of the hazards with an NG tube is that it's right proximal to the sinuses, and you're going to end up with sinus issues. So making sure that you do very good nair care. Make sure they're secured well. Whatever the securement device is, whether it's a stat lock or well secured with tape, you want to make sure they're well secured. Patients pull them out all the time by mistake because they're wrapped up in their hair or their ear. Make sure that they're well secured. Making sure that they're placed correctly. We used to listen to a gastric pop, and I know that you folks are aware that that's not evidence-based practice. It is really having a x-ray put in, and doing an x-ray as soon as they're inserted, and then checking that the placement is, but we can't be doing x-rays every day. So we look at the markers, and there are markers to say this is inserted 25 centimeters, and making sure that that marker is still at the place that it was the day before. Making sure that you are flushing it if it's supposed to be flushed. And if it becomes blocked, don't use Coke. That's not evidence-based. There's different medications that we use. Pancreolipase is one of them, and sodium bicarb. And we just leave that there so that that enzyme can erode at that. So I just want to thank you so much for participating in this presentation on nursing care of patients with GI health challenges. And I just wanted to overview that we've talked about acute abdominal pain, we've talked about GI bleeding, we've talked about ostomies, we've talked about GI surgery in general. And so I'm going to archive this for those of you who'd like to review it at a later date. If you have any questions, please don't hesitate to contact me. Thank you so much. And I'm just going to, if you want to take a quick break, stretch your legs, we'll launch into our neuro. So actually, I'm going to save this one separately. So is it difficult for everyone to sign back in again? I'm just going to ask if you wouldn't mind doing that, and I will. Thank you very much, and I'll archive this so it's not too long.